Hi everyone, my name is Lisa Zhang and I'm a fourth-year medical student at the University of British Columbia. I will be presenting this talk today on behalf of our research team. The title of our presentation is Improving Access to Sexual and Reproductive Health Services among cis and trans women living with HIV. Correlates of self-reported comfort discussing sexual and reproductive health with primary HIV providers. I also want to note that normally we would be doing this presentation with a co-author with lived experience living with HIV. Unfortunately, with the limits on in-person activities and technology barriers, we are unable to do this for the current presentation. I want to take a moment to acknowledge the critical contributions of all co-authors on this study. We do have several co-authors here today who can help answer questions. We have written this presentation into a peer-reviewed article that is currently under review with the Journal of Sexual and Reproductive Healthcare. I would like to first begin by acknowledging the land on which we work is the unceded traditional territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Importantly, over half of the participants in the study of women living with HIV, which we are presenting today, are Indigenous, including First Nations, Métis, and Inuit, while representing only 4% of the overall Canadian population. For the majority of participants in Shauna who are Indigenous, Canada's history of residential schools and settler colonialism embedded within centuries of systemic and structural racism have played a fundamental role as the primary social structural determinant of health inequities in Indigenous peoples in Canada. Access to sexual and reproductive health care is a critical human right and is especially important for people with complex health needs who have historically faced discrimination and stigma within healthcare, including cis and trans women living with HIV. As life expectancy and quality of life improve with advancements in antiretroviral therapy, women living with HIV are increasingly supported to consider their fertility options and engage in sexual health discussions. Therefore, many of these services are increasingly being integrated into the primary care services offered by many HIV providers. Even so, there is still evidence of an unmet need of sexual and reproductive health services among women living with HIV. This study sought to address the gaps in the current literature of access to sexual and reproductive health services in HIV care among cis and trans women living with HIV through examining the prevalence and social structural correlates, including HIV stigma, of having sexual and reproductive health needs met by participants' primary HIV provider. Data were drawn from a community-based, open, prospective cohort of women living with HIV, the Sexual Health and HIV/AIDS Women's Longitudinal Needs Assessment, otherwise known as SHANA, which was first initiated in 2015. Participants completed a semi-annual peer or community interviewer-administered questionnaire at baseline and 6-month follow-ups. The questionnaire covers social demographics and structural vulnerability, such as experiences of violence, food insecurity, sex work, and drug use, as well as various aspects of sexual and reproductive health access and outcomes, and questions related to HIV status. We examined 2 outcome variables that represented having sexual and reproductive health needs met by one's main HIV provider. We conceptualized having sexual health needs met as described in the first outcome, being comfortable getting a pap smear and/or discussing sexual health with participants' primary HIV provider. We conceptualize having reproductive health needs met as described in the second outcome, being comfortable discussing reproductive health and/or pregnancy needs with participants' primary HIV provider. We examined a number of explanatory variables, including the ones mentioned on this slide. The associations between these factors and the primary outcomes were analyzed using bivariate and multivariable logistic regression models with generalized estimating equations for repeated measures over time. Adjusted odds ratios and 95% confidence intervals are reported. Our study included 314 participants, and overall 77.1% felt comfortable discussing sexual health, while 64.7% were comfortable discussing reproductive health with their primary HIV provider at baseline. A third of our participants identified as members of sexual minority communities, which includes gay, lesbian, bisexual, two-spirit, asexual, queer, or other. The study sample included 8.9% of participants who identified as members of gender minority communities. Gender identity was defined as either a cisgender woman, gender identity as a woman matches their biological sex at birth, or trans woman, inclusive of gender identities of transgender or transsexual woman or other trans feminine identities. The sample included predominantly indigenous women, with about 1/3 of the sample being white and 10% were otherwise racialized participants. These tables showed the associations of key explanatory variables and having sexual health needs met in Table 2 and having reproductive health needs met in Table 3. Please note that only select associations that were significant in the multivariable analysis were included given the time and space constraints. In multivariable analysis, being comfortable discussing sexual health was inversely associated with sexual minority identity, gender minority identity, and enacted HIV stigma, and positively associated with accessing women-centered services at the Oak Tree Clinic, which is an HIV clinic in Vancouver that provides specialized, interprofessional clinical care to women, children, and their families living with HIV. Being comfortable discussing reproductive health was inversely associated with sexual minority identity, gender minority identity, and positively associated with accessing women-centered services and a history of pregnancy. Stigma is a well-documented barrier to accessing medical care, especially among people living with HIV. Our findings support the claim that HIV stigma, specifically enacted stigma, is a barrier to the uptake of sexual and reproductive healthcare services. Given that experiences of past discrimination by others cannot be prevented by a provider, this underscores the importance of creating rapport and building a trusting, non-judgmental, and non-discriminatory relationship with a patient in order to fully engage women living with HIV in sexual health services. These practices are a fundamental part of trauma-informed care, which has been increasingly advocated for among HIV care providers. Sexual gender minorities living with HIV have unique sexual and reproductive health needs that have not been historically considered within the scope of some primary care practices, including specific barrier methods for contraception and post-operative care for gender-confirming surgery. It is critical that HIV providers recognize the unmet needs of sexual and gender minorities living with HIV and make a substantial effort to involve these communities in sexual and reproductive health services. Upstream solutions such as increased education and training in sexual minority and gender-affirming care, in addition to institutional and policy changes to ensure accessibility to sexual and gender minority communities, should be implemented. Furthermore, our study identifies women-centered and trauma-informed HIV care as a strong facilitator to meeting sexual and reproductive health needs. The Oak Tree Clinic care model is built on a foundation of trauma and violence-informed practice and responsiveness to social structural health determinants such as poverty, drug use, housing, and HIV stigma, and prioritizes peer support and outreach. Collectively, these non-judgmental, supportive components are likely to strengthen trusting relationships between providers and patients and facilitate conversations about sensitive topics, including sexual and reproductive health. This is the first study, to our knowledge, that has quantitatively examined the correlates of an important relational aspect of access to sexual and reproductive health services that relate to the sexual and reproductive health needs of cis and trans women living with HIV. Further qualitative research conducted to support these findings would provide further insight to the pathways between variables. In conclusion, our findings suggest that there is an unmet need for safe sexual and reproductive health care among women living with HIV, and in particular for women living with HIV who identify as members of sexual and gender minority communities and those who experience enacted HIV stigma. HIV providers should create safe, non-judgmental, gender-affirming spaces for discussions on sexual and reproductive health to occur, and this can be facilitated through awareness, woman-centered, and trauma-informed approaches. We thank all those who have contributed their time and expertise to this project, particularly participants, peer researchers, community engagement associates, Shauna Community Advisory Board members and partner agencies, and the current Shauna team. Thank you so much for all your time.